This podcast is a production of OPENPediatrics, an open access online community of healthcare professionals sharing best practices from around the world. Visit openpediatrics.org for more.
Welcome to the World Shared Practice Forum podcast on Open Pediatrics. I am Jeff Burns, a pediatric critical care physician at Boston Children's Hospital and Harvard Medical School. We are very pleased to have with us today Dr. Kathryn Maitland. Dr. Maitland is professor of pediatric tropical infectious diseases at the Faculty of Medicine and director of the Eye Care Center at the Institute for Global Health Innovation, Imperial College, London. She is based full-time at the KEMRI Wellcome Program in Kenya. Kath, welcome to Open Pediatrics.
Thank you. Thank you very much for having me.
And Kath, I should say welcome back. The last time I spoke to you was late 2011. And at that time, you were visiting professor at Boston and Harvard Medical School with us. And you were also on Open Pediatrics discussing your really now landmark paper in the New England Journal, published June 30th, 2011, entitled Mortality After Fluid Bolus in African Children with Severe Infection. The Fluid Expansion as Supportive Therapy fee study was designed to investigate the practice of early resuscitation with saline bolus as compared with no bolus, the control, and with an albumin bolus as compared with a saline bolus in critically ill children with severe febrile illness and impaired perfusion in Uganda, Kenya, and Tanzania. And what you demonstrated was that fluid boluses significantly increased 48-hour mortality in critically ill children with impaired perfusion in these resource-limited settings in Africa. And I use the word paradigm shift because it truly was. It was, even for those of us who don't practice in a low and middle income environment, it opened our eyes to the possibility that less might be more. But the community, if I have to say, Kath, I think was slow to catch on. I think we were slow to acknowledge it in our environment, North America, Europe, etc. But I can also say, as Manhattan, president of the World Federation of Pediatric Intensive and Critical Care Societies, and now working closely with the WHO, that the WHO themselves were slow to acknowledge these data. And it wasn't until 2020 that the current WHO guidelines on resuscitating children in this context really acknowledged your findings and have adjusted the approach to fluid resuscitation. So, I have to, salute you again for that work that you did now 14 years ago. And you're here today because 14 years later, you're publishing in the New England Journal again. You published your study entitled Intravenous Rehydration for Severe Acute Malnutrition with Gastroenteritis. And you're here today because we'd like to talk to you about that study and what the motivation was for that study and what you found. And so, Kath, if I could turn this now to you, what was the motivation for your study that I believe you referred to it as the GASTROSAM trial? What was the motivation for the trial? What research gap was it trying to address?
Thank you. So I think I just want to put this, first of all, in the context of gastroenteritis worldwide, because I think that for most people, they won't see children dying of gastroenteritis. There are approximately 2.5 billion cases worldwide in children under 5. It is the second biggest killer. And most of those deaths will occur in low to middle income countries. So for children who come into hospital with gastroenteritis, they're 8.5 times more likely to die than children who don't have gastroenteritis. So that's telling you that this is a big killer of children. And we looked at the guidelines worldwide of who's doing research in this area. And this really is the silent emergency, because worldwide there has been no clinical trials in lower to middle income countries looking at the current recommendations. And only 3 trials have been conducted, and none of those have mortality. So completely not relevant to our context. So that's the global context just of gastroenteritis. Narrowing down to children with severe malnutrition, they frequently are admitted to hospital, and about half of them will present with diarrhea or gastroenteritis. their mortality is awful. Overall, mortality is around about 15 to 20%. But if they're complicated with severe dehydration and gastroenteritis, that can go up as high as 40 to 50%. So the outcome is absolutely dreadful. And what are the current recommendations for these children? If you don't have malnutrition, the children who are managed for severe gastroenteritis, they normally are assessed to have approximately 10% dehydration. So that's 100 mils per kilo. And they're recommended to give that. It's called Plan C. It's a very, very complicated two-stage process, two different rates for two different age groups. That's plan has to be given 100 mils per kilo over a short period of time between 4 and 6 hours. Remember, in the feast trial, we only give 20 mils per kilo. So that's a very, very liberal rehydration protocol. But if you don't have malnutrition, they recommend do not put an IV line in. Why do they recommend that? In other words, that children are recommended not to have IV rehydration. Instead, they're recommended to have oral rehydration. The major concern is that people have viewed children with severe malnutrition. There's two different phenotypes. There's the severely wasted one where children are bone thin, a huge lack of muscle mass, or the edematous type, often they coexist, edematous type called kwashiorkor. And both types are thought to be prone to heart failure. So they feel that it's too unsafe to give intravenous fluids to these children, including shock, etc. And they should not receive IV fluids, but only if they develop severe shock. So currently they're recommended to receive a low osmolarity, low sodium solution. It's a specific oral rehydration solution that's been made for children with malnutrition. And they say that this can only be given in a health facility, that meaning that it cannot be given in the community. So if you want to give any rehydration at all to a child who's got severe malnutrition, you've got to get them into the health facility. And this is probably some of the reasons why they've got an appalling outcome, because they're obviously coming in late with no pre-management, and even when they're in there. So this was something after feast we said we have to tackle. And we've basically layered upon layer before the trial started. We had to sort of say, is there evidence behind, the fact that there is a very, very strong belief, and this is very, very widely taught. It's one of the first things people are taught about children with severe malnutrition, about heart failure and incipient heart failure. Well, we looked for the evidence, and it really wasn't there. We did studies, about 250 overall between Kenya and Malawi, two separate studies that actually looked at myocardial function, and we found that it was actually normal. And in the study that we did in Kilifi, in Kenyan children, it published in JAMA Open in 2019, called CatMal, we actually showed that children had normal responses to fluids. In other words, their Starling curves responded in the same way that they would do if they'd had boluses elsewhere. So we were fairly confident this was, should be, sort of the WHO should act upon this. But really, the guideline that's been in place for 26 years has not changed. So still children with severe malnutrition are, I shouldn't say it, but because that sounds like loss of equipoise, but they are denied intravenous rehydration because it's felt that it is so dangerous to give it to children. So that's very high mortality, very, very low evidence base based on expert opinion. This guideline needed addressing. And in the 26 years that, a definitive phase 3 trial has not been undertaken, specifically in Africa.
Well, Kath, that was a beautiful description of the problem as it exists really around the world, as well as, of course, in low and middle income environments. So could you tell us a little bit about your trial design, and where did you undertake this trial?
Thank you. So the GastroSam trial was designed as a multi-center, investigator-led, individually randomized trial. It was registered before we started enrolling, and the protocol has been published. The trial design, obviously, we had to go back to the starting blocks to saying, well, we can't just make up a volume of fluid to give these children. We have to sort of stick with something that's already there. So we're saying there's a distinction between children who don't have malnutrition and children who do have malnutrition. So that's the starting block for the intervention arm. So we wanted to compare what's currently standard of care, which is control oral rehydration, versus a liberal rehydration. But from what we learnt in Feast, we were quite anxious about pouring. So you have a rapid phase, which is given over half an hour or an hour, which is 30 mils per kilo. And that's even after they've had shock. So we were concerned about that. And so our other experimental arm was a slow rehydration. So I'm going to go through those 3 arms now. So the control was, as I said, that's oral rehydration with this Resamal solution, where children were given over about 8 to 10 hours, about 100 mils per kilo oral. They were only allowed intravenous fluids if they developed shock, and shock was quite extreme. So it had to have, I think, 3 features of impaired perfusion. So that's that intervention arm. For the second intervention arm, this is the WHO Plan C. So that's what we call liberal rapid. So it's a rapid. So it's, first of all, the children were assessed for shock. If they had shock, they had a bolus of fluid, and then they went on to have their rehydration between 4 to 6 hours, depending on whether you were under 1 year of age or over 1 year of age. That, I'm telling you, it was very, very difficult to teach. People couldn't do it. We had to have perfusers to make them do it so they could follow this. And then nurses were back and tutored the perfusers to making sure that they were doing the right rates. And then we had a slow, a liberal rehydration arm. And that was just 100 mils per kilo, no boluses at all. Even if they had shock, you went straight on to receiving your rehydration therapy. And that was given over 8 hours at an even rate. So that's the 3 intervention arms. I didn't say who were incorporated in the trial. Clearly, children who had a severe acute malnutrition, and they had quite severe diarrhea, over 3 loose stools, and then severe dehydration, which is any of 3 signs of severity of dehydration. Initially, the trial took place in East Africa. And it was in 4 sites there, 2 sites in eastern Uganda, and 2 sites in the coast of Kenya. These sites represented areas where you have stable undernutrition in the community, which then switches quite rapidly into severe malnutrition when they've had a clinical illness or a clinical event that sort of brings them into there. So you see malnutrition all year round. Later in the trial, were brought in just so we could complete the trial numbers. There were the huge sites in West Africa, in Niger and Nigeria. And both of those sites are in the humanitarian context. They were both being run by Médecins Sans Frontières, or what you would call Doctors Without Borders. They have a seasonal malnutrition where you have huge numbers coming into these clinics. It's the Sahel hunger gap, and where you have kids pouring into these enormous refugee camps, and the being able to manage these children, obviously, is the burden of those is just a massive undertaking, and that's what Médecins Sans Frontières do very well. So the context, again, in which the trial was run is that they were generally managed on the general pediatric wards in the East Uganda sites, whereas in the Niger and Nigeria sites, they were managed on what we call a high dependency care unit, where you didn't have access to mechanical ventilation, but you had a very, very close, you had a team around you that gave you 24-hour care, and also very, very sort of all the other supportive care that you could get in the context of a sort of high dependency care unit. I'll tell you a little bit about the challenges a bit later, but that's really the design and the trial, the characteristics of the site. Just wanted to say that all children received standard of care. So there was, apart from the randomizations of the oral and liberal rehydrations, they all got the same standard of care. So they got a package of care. And we then monitored the children very closely because of the concern that we were going to put these children into heart failure. So every 30 minutes for 2 hours, then hourly for 8 hours, and then at 12 hours and 24 hours thereafterwards. And doctors, when had to go to the bed, each of these time points, they had to go and look at the patients. Obviously, they had to have the whole range of bedside monitoring done, but also actively solicited signs of fluid overload. They'd all been taught how to do this, and so these were recorded at each review, and all of the data was collected onto standard forms. So yes. And we had external oversight by data monitoring committees, who were the only people looking at the data over the time points, and a trial steering committee.
Well, Kath, sitting here in Boston, North America, our problems seem quite far remote and somewhat insignificant compared to the chronic malnutrition that you just described in your East Africa sites and the episodic and devastating malnutrition that you see in your West Africa sites. Could you tell us about the outcomes that you were trialing, and what were what were your key findings?
Okay, so the primary outcome was mortality at 96 hours. We had secondary outcomes of mortality to day 28 and a number of anthropometric outcomes, change of weight, mid-upper arm circumference at day 3 and day 7. Important in this trial were the safety endpoints. This trial was about safety. So those were the headlines, and secondary and safety endpoints were evidence of pulmonary edema or heart failure, but also the development of shock. And particularly, obviously, thinking about the oral rehydration arms. We had a number of biochemical endpoints, change in sodium at 24 hours after the completion of our intravenous rehydration. The reason why we had that is there's the additional concern. Not only are they concerned about the children are prone to fluid overload, it is said in the guidelines, we have not been able to find any evidence why, but children with severe malnutrition cannot cope with a sodium load. That's the additional rationale for not giving them sodium-rich solutions. So we wanted to see whether there was, issues sort of over giving them hyponatremia as a result of our giving them sodium-rich solutions. And our main comparison when I present the results is it's liberal versus control. So when you're looking at the numbers in the sort of statistics, the major comparison is liberal versus control. Although we did secondary analysis over the different types of liberal versus control, the main outcome was liberal versus control. So just going on to the results. Were these children that came into the trial, I think it's important to highlight in the baseline, these were very, very sick children. A child who has a normal anthropometric indices, weight for height Z-score would be around 2 or 3. If you were normal, these children had height for weight Z-scores of almost -5. These were horrifically undernourished children. Quite a number of them had been previously admitted for malnutrition, although their median age was around 12 to 14 months. Many had very, very poor appetite. They were unable to retain any oral fluids, about 80%. Altered consciousness was very prevalent, for about 40%, 30 to 40%. We found that in their biochemical measures at baseline, 53% had very severe hyponatremia. That's a sodium below 125 millimoles. I think you probably rush somebody to an ICU if you saw something like that in your setting. Also of note, 40 to 50% of children had severe hypokalemia. That is a potassium less than 2.5 millimoles per litre. Up to about 12% had a positive blood culture, and most of those positive blood cultures was gram-negative bacteremia. So just to highlight that these are very, very sick children. These are all high risk factors for very poor outcome, as we'd previously seen. So during the trial, The adherence was absolutely excellent. Everybody adhered to the randomization. This was a result of us all sitting down at the beginning and saying, if we run this trial badly and you go with what you believe rather than following the protocol, then what we'll come up with is a mess at the end, and we won't be able to publish it. And that will be, when, all of those children that said that they were going to go into the trial, you've not done them any service. So people absolutely adhered to the protocol. So that means the results are credible. We had a very, very high retention rate, meaning that we didn't have to do a protocol analysis for both of those reasons. Fluids were started on the IVs in the pooled liberal arms within 14 minutes of them being randomized. So they got their fluids and they got the right volumes. What we did see for the children who were in the oral arm, at the beginning, nearly 10% needed a bolus of fluid because they were in shock. Quite another number afterwards also had to be corrected for shock. But also in that oral arm, because they were still profusely vomiting, 93% had to have a nasogastric tube inserted, effectively for nearly all of them to actually receive their intervention. If we go to the primary and secondary endpoints, the primary endpoint, mortality at 96 hours, overall there was no difference from the control to the pooled liberal. The control was 8% and the pooled liberal was 7%. This is at 96 hours. So obviously the statistics showed there was no difference between those arms. There's similar mortalities between 12 and 10% overall at day 28. We saw a much higher urine output in the liberal arms versus the control, which is probably not unexpected. The number in the control arm who developed a serious adverse event, although numerically higher than the other arms, it wasn't statistically higher. And although we were giving very, very rapid rehydration to these children, we were concerned about their whether they developed any neurological events. We didn't see any. Numerically, more children in the control arm developed shock after the start of their intervention. So when we actually look at the safety outcomes, again, this trial was about safety, we saw in all of the children in the trial no episodes of pulmonary edema and no episodes of heart failure. And this is not because the doctors weren't trained how to do this. They were all trained in the same, and then we didn't see any episodes, which was very reassuring for safety. We saw a better time for correction of hyponatremia in the liberal arms versus the control, but we didn't see, only 2% overall, and this was the same across all of the arms, developed hyponatremia, which again was another concern about giving sodium-rich intravenous fluids. So our conclusions were that while we had no difference in mortality at 96 hours, we might have felt deflated about that. But we have to almost celebrate the fact that these children were so well looked after that we, in general, brought down mortality from what we'd expected to be around about 40% down to 6 to 9%. And that was really because they were it shows the value of actually being enrolled in a clinical trial, but it was also due to the increased levels of staffing and the quality of care that they provided, the bundle of care that they were given, and that adverse events were quickly picked up and also then managed. But reassuringly, we saw no evidence of fluid overload, which is an enormous step forward.
Well, Kath, it's fascinating to hear you describe the results of your trial. And I must confess, I'm sitting here thinking to myself, which outcome is it? Does your trial prove that there is no harm in intravenous hydration, as was the dogma, as you noted, prior to your trial, and that intravenous hydration, as you administered it in that environment, is as efficacious as oral rehydration? Or is the message from your trial, in your view, that oral rehydration continues to be effective, and certainly as effective as intravenous hydration as you administered it. And therefore, because it's a less complicated and likely more available, obviously, method of rehydration, that oral rehydration remains the primary focus in your environment. Which outcome, which interpretation do you take from your study?
Yes, thank you. I mean, some people may be reassured that oral was as good as intravenous, but I think you have to look at how we ran this trial. We ran this trial because ethics required us to be almost at the bedside during the entire time when the children were receiving their oral rehydration or intravenous rehydration. Um, that in reality would just simply could not happen. We're looking at busy pediatric wards whose bed capacity is often 2 or sometimes 2.5 times oversubscribed, where you have few staff, um, and giving oral rehydration they indicated that it might need to be given by a nasogastric tube, but this is the first indication that in order to make oral rehydration effective, that you have to literally be by the bedside and administer it and through a nasogastric tube, which is not easy to do. It has to be checked each time you administer the next dose of oral rehydration solution, and it's not without its own dangers. It was done safely because we had a dedicated team. Um, we asked all of the teams in a meeting afterwards, what would you prefer? And they all said, gosh, intravenous, the slow arm, because it's just so easy. There's just little sort of calculation you have to do at the beginning, and just and then let it run. Obviously, you have to go and check the child, but if you're thinking of the context, then that is the simplest option. Again, we saw across all arms no evidence that this caused fluid overload, and continuing to recommend oral rehydration from all that we have learnt in the GASTROSAM study. So this was also a demonstration of how not to make a guideline and thinking it was simple. But it's also has implications beyond that, because it is not recommended that children with severe malnutrition in the community, and many do get managed in the community, they should not have oral rehydration solution, because you've got to get to hospital to get that in orally. So again, it means that probably more children die than that is necessary. This was an overall demonstration of the safety of a more a standard way of giving rehydration, I think.
Kath, where do we go next? Do we need more trials like yours to, convince policymakers, et cetera? Where do we go next with this?
I think we don't need any more trials. The guideline was put in place to protect children with malnutrition from people giving them IV rehydration, which would cause them harm. We have demonstrated it is not harmful. We've also demonstrated the huge challenges of giving oral rehydration solutions. They hadn't anticipated the high number requiring nasogastric tubes, 90%, that 22% needed boluses because they were in shock or developed shock. I think we desperately need to simplify rehydration guidelines for children in resource-limited settings, and that there should be no distinction between those who are well-nourished and those who are malnourished.
Well, Dr. Kathryn Maitland, it's a privilege to have you back on Open Pediatrics 14 years after your FEAST study. And we've been discussing with you your trial published in the June 13th, 2025 issue of the New England Journal of Medicine, entitled Intravenous Rehydration for Severe Acute Malnutrition with Gastroenteritis. Kath, it's late in the afternoon for you in Kenya, but on behalf of all of our colleagues around the world, I just have to say that we are extremely grateful that in our community, we have someone like you who's doing this research on things that really matter. And so, Kath, keep going. We look forward to your next trial and your next podcast on Open Pediatrics. Thank you for joining us today.
Thank you. That is very sweet of you. I feel quite humbled.
This has been a production of Open Pediatrics. You can find the resources and journal articles referenced in this podcast in the description. We have more podcasts like this one available everywhere you get your podcasts. Visit openpediatrics.org for more information.